Okay. Good afternoon, Madam Chair and committee. I'm so pleased to be here with you this afternoon. My name is Donna Boatright, and actually Ms. Dudensing and I hail from the same city in West Texas. I'm from Sweetwater, Texas. I am.
Is the water sweet there?
Yes, ma'am.
Okay.
Absolutely.
Okay.
It
All right.
is.
Okay.
A lot of jip in it.
You didn't bring in the bottles for the committee, did you?
I did not, but I could have some sent.
Well, now just make sure this is your last time coming without a bottle of water.
Yes, ma'am. I will never
All
fail
right.
to do that again.
We're going to let you off this time.
Oh, thank you.
Okay.
I'm a registered nurse of some 43 years, and I'm also the CEO at Rolling Plains Memorial Hospital in Sweetwater in Nolan County, which is an interesting rural community that sits at the crossroads of highways 84, I-20, and Highway 70. So we're really situated sort of in the center of the state, about 180 miles west of Fort Worth and 100 or 230 or 40 miles southeast of Amarillo. So right out in the middle of the cotton fields and the wind farms. So we're very happy to be here talking about rural health response to COVID, and I'm here representing the Texas Hospital Association and the Texas Organization of Rural and Community Hospitals. We have had a very busy flu season in rural Texas as well as across our state, and that puts us in an interesting position in going into this season. Am I ringing? I'm hearing a little ding, 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 so I apologize. I don't have Tinkerbell in my pocket or anything like that. I just sound a little dingy. We are going in after a stressful time in our small hospitals, in particular with our stress on our staff and on our resources, and puts us in a particularly interesting situation going into this threat to our health and our country and our state. We have had a lot of work in our community discussing our preparedness and what we can do to, hi doctor, to be able to prevent the spread and also address those needs. And one of the things that I would like to mention to you today is that, as other speakers have said during this interesting panel today, that we have spent a great deal of time inventorying our supplies, inventorying our resources, be those our disposable PPEs, our bed capacity, ventilators, and certainly staff. And those have been looked at from a perspective of not only what the most disastrous situation could be, but how we would address it should we be faced with the droplet situation versus an airborne situation. And fortunately, we do have negative pressure facilities in my hospital, but some rural hospitals, that's a fairly limited situation. And so those resources could be stretched pretty thin depending on how that looks. We have had some experience in the rural hospitals with not being able to access some of the disposable supplies that we've needed. My hospital has been very fortunate in having those supplies necessary until today, and while I was in this committee meeting, I received a text from my purchasing agent saying that we cannot get any hand sanitizer through either of our group purchasing organization suppliers, and so we are in the process of looking at how we can handle that in Sweetwater. But we are not alone. Other rural hospitals have already faced this situation, and I have friends who have contacted me prior to this meeting that have gone to Ace Hardware and other places to buy supplies so that they could have adequate supplies in their hospital, even to the point of buying masks from time to time that are used to mow your lawn when you're out mowing your lawn. So just know that we are still facing some of those issues and trying very hard to access resources where we can. I particularly have seen restrictions from our vendors, not for some of our routine supplies, but certainly if we order 4 cases of face shields, we may only get 2 cases of face shields. So there is some conservation going on with that, and we are not complaining about that, because we do know that that's important for the state and the country as a whole, but just keep in mind that those things do become more difficult. One of the anecdotes that I've had recently, we buy a case of 50 face shields for about $30, and I've had some of my colleagues in other rural hospitals that have paid up to $350 for the very same count of face shields. I see you shaking your head.
That sounds like price gouging.
Yes, ma'am, and I do want to say that our governor and our attorney general, I have to applaud them for speaking out so harshly this last week, not condoning that, and also just promising that there would be repercussions for companies that price gouge during this time of crisis in our country. As you know, in our state, we have about 70% of our counties that are in rural areas, but only 157 of our about 600 hospitals are in rural communities, and we've had close to 30 hospitals closed since 2013. And so it leaves a large area of our state in a somewhat precarious situation, and the hospitals that remain there are committed to their communities, and I think that you will find that all of us are working hard to not only look to the needs of our community on a day-to-day basis, but also for those needs during this situation and how we'll be able to address that. Some of the concerns that we've had, some of the things that we've faced, is that our public is also feeling the squeeze on some of the items that they need, just like we are feeling that in our purchasing efforts. And so we've had to recently move PPEs that we generally have at our entrances into our facility for the public to put on if they have a cough, or to be able to clean their hands with the sanitizers. We've had to move those behind our registration desks just to prevent them being taken, and I'm sure out of concern and desperation by our public, but we've had to be able to conserve those. So that's one of the issues that we've had to deal with just recently. We also have a concern with staffing. As you will know, in many of our small communities, we may have only one physician or 2 or 3 providers that are available. I'm in a fortunate position to have a few more than that, but those providers can be stretched very thin when we have people that are either exposed or that are concerned that they're exposed, in addition to doing what doctors and other providers and professional staff do every day. Security is not something that I've heard mentioned today, but I would like to just say that in a small hospital, having security is a definite concern that we have. It's you. And I have fortunately have a security person on the campus 24/7. That's one security person on campus, but many of our small rural hospitals do not. And so we have to think in our planning process how that would look if we have a community spread situation, or when that becomes an inevitability, and how we would address those needs to make sure that our campuses are secure, and that our patients are secure, and that our staff is secure. And so those are some of the planning issues that we're looking at. Turnaround time on testing, of course, is at this point has not been a big issue for us, though we have had one dry run with a patient that presented with 2 of the symptoms, did not meet the criteria for foreign travel, but that we did go through the isolation process and then had communication and on-site with our local health department and communication with the state health services. And it was decided that the patient did not need to be tested. But we anticipate what that turnaround time will look like, just like we did during the SARS situation. Does that mean that we have to keep the patient isolated and our staff tied up under those circumstances for 96 hours or longer, depending on what those processes look like? And so it just keeps it as part of our planning procedures, how we will deal with that. I also want to mention at this point that we are very fortunate in Nolan County to have a local health unit, and that puts us in a great situation for communication. But we've also availed ourselves of the daily calls, of the weekly calls, of all of the information that's coming out of our state agencies and our federal agencies. And so I want to say that to mention that communication is, I think, one of our most important defenses against not doing well in addressing our needs. We internally communicate on a daily basis in a hospital-wide huddle to talk about what the statistics are looking like, if there's been any changes across the state or in our area, or edicts from CDC or from the state health services, and make sure that our staff has a good understanding of what's going on. And the one place that I think that we could do a better job with that is in making sure that our community is as well informed as we try to make sure that our hospital personnel are. Anticipating surge-related issues, we also are fortunate enough to have a number of beds that we would be able to use should we need to hospitalize patients, but fairly limited, as I said, on the ventilators and other types of equipment. Our medical core, our MRC, and our community is very strong, and we anticipate that they're going to be able to help if and when we get to a point where there is, a more widespread screening process that needs to take place and people that are concerned. And we also are looking for guidance on our telemedicine opportunities and alternative screening sites so that our emergency rooms and our doctor's offices can continue to operate to care for the other types of illnesses in patients that we see on a daily basis. And we also want to protect our ability to still do surgeries that we need to do. And when we run into shortages on masks and gowns and those types of things, then we have to seriously start considering what we do about elective surgeries and how we move forward with that. And those have many implications on health, but they also have financial implications in our small rural communities that I think are important. And with that, I will say thank you and glad to be here and take questions. Yes, sir.
Thanks. We've heard several.
Go right ahead.
Thank you. We've heard several comments about the importance of telemedicine, and you can certainly see in a coronavirus situation and in rural areas that would be a big issue. We've done a number of things. Is there legislatively to try to open up that ability? Are there any remaining legislative barriers that you're aware of that would make it difficult to do telemedicine?
I'm not aware of a legislative barrier. Carrie, do you want to mention? I know that there was a discussion. John Henderson and I had earlier. She is soon.
So if you would just
if you want to
ask
ask that, one thing that I would like to say is part of telemedicine has to do with equipment needs and those kinds of things. And telemedicine does not have to just be face-to-face with high-tech equipment. We envision that we could even, and we do have that capability in my hospital, but we envision that there is even value in being able to put an advanced practice provider on a telephone answering service that can sit down and help a patient walk through a screening process to help them determine if it's necessary to show up in a doctor's office or an emergency room. So we anticipate being able to use call centers for that as well, sir.
Okay, thank you.
Okay, Mr. Brent.
Thank you, Chair Thompson, and members of the House Public Health Committee for the opportunity to speak on the subject of planning regarding this new novel coronavirus and the concerns for an impending pandemic in our great state. My name is Brent Kaziny. I'm a pediatric emergency medicine physician at Texas Children's Hospital. I also serve as the medical director of emergency management for the hospital system. But I wear a number of different hats, so I'm also involved in the AP level in the state. I serve as the disaster contact for the state chapter of the American Academy of Pediatrics. And do some national level work with EMS for Children. We house the EMS for Children Innovations and Improvement Center at Texas Children's Baylor College of Medicine. And so through some of these things, I've had a variety of opportunities to be engaged in disaster response from kind of all levels, locally at Texas Children's through things like Hurricane Harvey, as well as, working on a more national scale, improving preparedness and response, in particular for the needs of children. I'm grateful to be here providing testimony on behalf of Texas Children's Hospital, the Children's Hospital Association of Texas, and the Texas Hospital Association. And I actually spoke before this committee 3 years ago in the wake of the Ebola outbreak on the subject of disaster preparedness, and hope to provide some insight for this committee as to how hospitals are preparing for this coronavirus outbreak. As you all may know, Texas Children's Hospital is the largest freestanding pediatric hospital in the United States and aims to provide the highest quality of care to children, not just in Texas, but also throughout the world. The Children's Hospital Association of Texas and the Texas Hospital Association assists the Texas Children's in its mission by providing a unified voice for all hospitals within the state. Both of these organizations recognize the importance of Texas Children's seat at the table as a voice for children throughout the state. While hurricane and weather-related events have historically been a key focus of our emergency preparedness plans, we've also shown a commitment to being a leader in pandemic response, as well as responders to high-consequence infectious diseases that threaten our community. And I'm going to give 2 examples of how I feel like we've responded to those in turn. And I think both of these responses have actually played a very interesting and important role in this current coronavirus outbreak. So the first example I'm going to speak to is when we enacted what we call our Mobile Pediatric Emergency Response Team. The first time we actually did this was in the shelter in the Reliance Stadium complex post-Hurricane Katrina with the displaced persons that were in that mega shelter in Houston. Number of children in that shelter, and Texas Children's took it upon themselves to build a clinic in that shelter, and over the course of 2 weeks cared for greater than 2,400 children that needed clinical care that didn't have a clinical home because they had been displaced through the hurricane. We actually used that same concept during the H1N1 pandemic in 2009, when what we saw was when the first pediatric death from H1N1 was announced as occurring at Texas Children's, we had a spike. Our average ER arrival rates are around 220 visits a day, and that went up to 366 overnight. So a massive spike in arrivals to our emergency centers. And we said we have to do something to deal with this increased surge. And what we did was we enacted the same thing, this Mobile Pediatric Emergency Response Team model, built it in the parking garage across the street from the emergency center, and we're able to see on average 65 kids a day through that center open 24/7 during the kind of prolonged response to H1N1. In addition to pandemic planning, we've also been involved and engaged in planning and preparing and responding to high consequence infectious diseases. And I think this is most kind of exemplified through the build out of our special isolation unit at our West Campus. So in the wake of the Ebola outbreak in 2014, Texas Children's approved the construction of a $16 million pediatric specific biocontainment unit at our West Campus. It's currently the largest pediatric unit of its kind and holds 8 beds to care for children with high consequence, highly contagious infectious diseases. It also has a biosafety level 3 lab, 3 autoclaves to assist with waste management, and a number of staff that are involved in quarterly training looking at maintaining high level involvement, engagement, knowledge of personal protective equipment, how to put on and take off this equipment so you don't infect yourself or others. We do quarterly simulation-based training, so we have high-fidelity mannequins in the unit that we train on. And we've seen simulated patients with everything from Middle East respiratory syndrome to monkeypox as we try to kind of see what's going on in the world and see what might be coming down the pipeline next. As you can imagine, the last simulation that I was involved in last month, we did coronavirus. So we've been working on this. It makes obvious sense that we would be working at this and focusing on this at this point in time. And we've had a number of patients under investigation that have already gone through that unit. So there's already a tremendous effort underway across our institution with an executive steering committee, of which I am part, but I felt it was extremely important to be here with you all today sharing this information. A variety of work groups have already been formed and are preparing and planning for all eventualities. We've been faced with a number of challenges that we are certain are universal concerns. Among these, and I know you've heard this a lot today, is the availability of personal protective equipment, or PPE. While we perform routine infection control on patients with viral symptoms during the winter months, so that means you come in with fever, cough, we put a mask on you, your family, we should be wearing a mask, gown, and gloves. Those are things you should be doing all of the time. Now, maybe not the same type of mask that we're talking about, a lot of the N95 or some of these other things, but a surgical mask, gown, and gloves as contact isolation for viral respiratory symptoms. That's something we do a horrible job of, just like people do a horrible job of washing their hands.
How do you clean it? I mean, if you're going to use gown.
All disposable, yeah.
Disposable
Yeah,
gown.
it's all disposable. So again, you can imagine if we just went to where what we should be doing, just like people are saying there's shortages of hand sanitizer, we're going to run out of these disposable equipments quite quickly, even though we've stockpiled these. And I think Texas Children's, their supply chain, does a terrific job of working with our vendors to make sure we have stockpiles. But even these patients under investigation require the great outlay of personal protective equipment in the form of the masks, et cetera, that we use, just for a presumed questionable patient that you don't even know has coronavirus. We've seen and heard messages from Seattle and Seattle Children's Hospital where they have essentially called out to all the children's hospitals across the country asking for personal protective equipment. And we recognize that we feel like we're ahead of the curve on this, largely because of the presence of our special isolation unit and stockpiles of N95 alternatives that we have, such as powered air purifying respirators or kind of the helmeted hood thing that you may have seen on the news or in other places. There has also been a massive multi-institutional effort looking throughout the Texas Medical Center at ways that we could enact testing sites throughout the city to keep people away from hospitals that don't necessarily need emergent medical care but are interested in testing should they have symptoms. However, those efforts have really been stalled because of the lack of personal protective equipment to appropriately and safely keep the people that would be doing that testing safe in these environments. I think really what we need to look at when we think about these concerns and questions for personal protective equipment is really that manufacturers are being impacted by this pandemic that's resulting in a decreased production and increased demand that's akin to when we saw the IV fluid shortage out of Puerto Rico after that hurricane season. And we really need to work on diversifying the manufacturing infrastructure for these and other healthcare related items to prevent this from happening in the future. I think another significant challenge is the global spread of accurate and up-to-date information for our communities. We've already created websites, engaged social media and the school districts, as well as our other relationships in the community. However, in a society that routinely inappropriately uses emergency departments, we know funding must be devoted to a massive statewide media campaign informing our citizens to stay away from our hospitals unless they are in need of emergency care. On a daily basis, our emergency rooms are overrun with patients that don't require ER level care, and the system as a whole has little room to surge when events like this occur. Like I mentioned, we've developed plans to implement our mobile pediatric emergency response team at all three of our emergency departments, similar to our H1N1 response, and have system-wide triggers in place. The goal of this isn't just to offshoot those patients that would be coming to the emergency center, but also to protect our extremely vulnerable population. Children with cancer, immunocompromised children, children with all these comorbid conditions. It's very fortunate that it seems like this is not affecting children in a significant way, but the population that we care for every day, this complex medical population, is extremely vulnerable to this. As we've heard earlier today, our local health departments serve as the front line against outbreaks like this. However, they are sorely underfunded and in desperate need for additional staff to fill call centers that can give accurate information to concerned citizens.
Let me ask you something.
Sure.
The test that they're utilizing for the coronavirus, is that the same one that they use on children?
Yes, it is the same test.
So if you have a stockpile that at your hospital and kids are not usually unlikely to get it, they don't get it as frequently as some adult part of our population, then you all can let them have your test.
So I think the question would be, though, are kids not getting it, or are they not getting it and not manifesting as severe symptoms? So I'm actually, one of my biggest concerns, I think, is actually not that our
It's
kind
an
of
agreement.
well population that we care for every day is going to get sick, but that we as healthcare workers are going to get sick. And anticipating a 30% decrease
Kids may
in
have,
work,
but what they have may not make them sick.
cough, cold, flu-like symptoms at most. But they're going to come to the emergency center because they're afraid they have coronavirus. They're going to cough on me. I'm going to get sick. Then I'm going to give it to my mom who has cancer. Say, these are the scenarios that I think we're concerned about.
Now, the person that's coming to your ER, are those persons with medical coverage?
All takers. All takers.
Okay,
Yeah.
okay.
So I think some of the things that
You
I
think it's
think
because of they panicking?
we haven't seen a massive spike yet. I anticipate when we see local transmission, that will happen.
Okay.
If you look at kind of historically, again, if you look at H1N1, when it hit the news that there was a pediatric death from H1N1 at Texas Children's Hospital, the floodgates opened. And I expect to see something similar to that when we see local transmission, or kind of worst case than that would be that unknown patient. So the patient that doesn't have a travel history, they don't live with someone that has a travel history, it just came out of nowhere. And we don't know through our public health and epidemiology means, we don't know where they got it from. That, I think, is when there's going to be this surge of concern, or people that are, otherwise well, maybe with the flu. I can tell you that in the shifts that I've done in the last week, every parent that's come with a child with fever, cough, congestion has said, what about coronavirus? Now, I don't think they think their child has it, but it's definitely on their mind.
They want to rule it out.
They're definitely thinking about it. And we've developed a test in-house at Texas Children's. We went live with it today, but it's very limited capacity at this time, and we would only be using it for registered inpatients, presumptive testing prior to obviously coordinated testing with the city, state, and CDC. I do think the other couple of things that have been mentioned previously, as well as things looking at institutions looking into telemedicine options, I think is a huge thing. And we have increased greatly our capacity to do telemedicine in the past 2 weeks is a specific response to this, which I think is a fantastic kind of secondary outcome from this. However, we need to look at some of the things regarding reimbursement, in particular how that relates to reimbursement with Medicaid, as I think that could pose some issues and problems. I would say lastly, centers like Texas Children's that have kind of gone above and beyond and created this special isolation unit rely on grant funding through the government to maintain these operations. To do quarterly training for over 60 members of this special isolation unit is a labor, time-intensive, and financially intensive prospect that really needs to be continued so that we can continue to be that frontline barrier to these things going and evolving from this kind of person under investigation phase that we're at right now to pandemic phase where this is everywhere. So I've kind of been talking a lot the last couple of days, so I feel like we're almost thinking about this like Ebola now, right? We have PUIs, there's travel history, there's these risks, but at some point it's going to be H1N1. And it's hard, I think, for us to make that mental transition between those two phases, and we're kind of in between there right now, where some places are seeing this and some others. The marathon-like efforts of pandemic planning are underway, but without ongoing government support, the system will be tremendously challenged. I, again, appreciate the opportunity to share my knowledge and shed light on these efforts at Texas Children's. I'd be happy to serve as a resource for this committee in the future, and in addition, I would love to host any of the committee members or your staff that would like to visit Texas Children's in our special isolation unit. And if anyone has any additional questions, I'd be happy to answer them at this time.
Thank you.